Greetings. I am Marcy Witherspoon, a Senior Training Specialist for the Health Federation of Philadelphia, and I function as the Family Violence Specialist for AHS. I'm offering this recorded training in lieu of the in-person IPV or DV trainings that I have been doing for AHS at each of the city health centers for the last almost 20 years. Today's training will be about the intersection of HIV and IPV. I'd like to start by first giving you a warning that the material that I talk about can be triggering. If you are living with or have lived with IPV, some of what you see or hear today may trigger some discomfort, some painful memories, even some flashbacks, or any number of trauma responses. Please do what you need to do in order to take care of yourself, whether that be to pause the recording at various points or even to stop it and watch at another time. The objectives today will be to examine the intersection between IPV and HIV, to identify the reasons why there is such a high co-occurrence of these two issues, and to describe ways to address this issue to reduce the numbers. For those of you who may be new to either issue, here's a quick review of definitions. IPV, or intimate partner violence, is a pattern of controlling and/or assaultive behaviors that an adult or teen uses against an intimate or dating partner in order to gain power and control. These behaviors can be physical, emotional, psychological, financial, sexual, reproductive, etc. And HIV is human immunodeficiency virus, which interferes with the body's ability to fight infections. HIV is now a chronic, manageable disease, which can be controlled by medication and self-management. In my estimation, not enough time is spent on the co-occurrence of these two issues. For example, in DV organizations in the city, there is no data that is collected on the HIV status of their clients, despite the high numbers. From the HIV perspective, HIV patients are typically screened for the presence of IPV. As a matter of fact, medical case managers from ACO are required to ask two questions. Does somebody hit, punch, or kick you? And do you feel safe at home? Those are two adequate questions, but much more than that is needed to encompass the full scope of behaviors that fit under the umbrella of IPV. So it's way more than just physical. That doesn't capture any of the controlling behaviors. This point is made very clear in this graph by the CDC that was developed 2 years ago. And the top image demonstrates that about 33 1/3 of women in the United States experience IPV at some point during their lifetimes. And the bottom image describes that 55% of women in the United States who have HIV are impacted or experience intimate partner violence at some point in their lifetimes. So we see that having HIV really bumps up the statistics. So we know more than half of women then with HIV experience IPV. So we really need to do a better job screening and identifying who these women are to protect them and to support them and to provide them options and resources. I also wanted to have you take a look at not only the intersection between IPV and HIV, but also to include two other pandemics, one of systemic racism and one of COVID. With all of these issues, what we see is that underserved, under-resourced, and more marginalized populations are impacted more severely. So whether it be structural issues, policies, practices, whether it be explicit or implicit bias, we know that health disparities are caused by health inequities. So when we go back to the two issues at hand that we're focusing on today, even though they are impacted by the previous slide and other issues as well. When we look at the issue of HIV and the issue of IPV, also which impact populations of color in ways that are more severe and where there are fewer resources, fewer culturally competent and linguistically appropriate resources. What we know is that social stigma is present with both of those issues. That's what they have in common. And the stigma actually permits and in some ways perpetuates these conditions because they make people silent about them. And it's because people have been judged, they've been embarrassed, they've been humiliated, they may have been rejected or even ridiculed as a result of either having HIV or experiencing intimate partner violence. And that attitude seems to persist, even though we should know better. I'd like to play an excerpt from this interview with Tanya Lewis Lee and 5 female survivors of IPV who are HIV positive. It is an excerpt from a 22-minute interview, which, if you get a chance to watch, is very moving and powerful and informative. Here's what they have to say.
I often tell people, HIV doesn't care how much money you have in your bank account. HIV is a disease of opportunity, and the dynamics switch even more when there's intimate partner violence involved in that.
I didn't even identify with being in a violent relationship because I thought that was right. I never looked at unhealthy relationship and saw myself.
Many times they used HIV against me. You should be glad that you have someone to love you because who's gonna want you with HIV?
We're with these men who are abusive and they don't want to use condoms or they don't want us to go to the doctor.
Living with HIV is nothing to be ashamed of, and it's changing the voices in your head, because when you're repeatedly told that you're stupid, that you're no good, you begin to repeat that in your head.
Why are my T-cells always so low? And that's because of the stress and the depression.
I knew if I gave him a chance to say, I'm sorry, if I gave him the chance to say, I didn't mean to do it, then I would probably still be there today.
I waited till he went to work. I acted like nothing was going on. I got out and I ain't looked back. I left. When I left, I left.
It's about me being healthy. It's about me being well and me getting what I need out of all of this.
With new treatments, there is hope.
And we can live a normal lifespan, and it doesn't change any of our worth at all.
I found that there is life outside of this diagnosis. It was just waiting for me to find it.
So some of the messages that I gleaned from this excerpt are that one, trauma in childhood, so intimate partner violence in childhood, that is either has not been talked about, has not been resolved or healed from, or even if it's normalized, raises the risk for intimate partner violence to occur in adult relationships. What we know from research is that boys are at a higher risk of perpetrating violence if they themselves were exposed to it as children. Another point that was made by one of the speakers was that many survivors have felt that their self-worth, their self-esteem, that their value has been eroded. And we know that there's an emotional or psychological component to each form of domestic violence. And they have really struggled in subsequent relationships and have had lots of trouble learning to trust again. And another message was that the focus when we're working with patients or clients needs to be a holistic one, a holistic approach where the whole person is being looked at, not just the T cell count and viral load. So if a patient can't get enough sleep, or if a patient is under stress, or can't take medication, or attend medical visits, then her ability to maintain her condition is severely compromised. So we really need, in that way, to be focusing on the social determinants of health. This is the HIV Power and Control Wheel that was developed by the National Network to End Domestic Violence. It is formatted similar to the original Power and Control Wheel that was developed in Duluth, Minnesota, some 40 years ago. The subheadings, which are small, I already also have listed on the side of the slide. And the subheadings are not that different than the subheadings that are in the original Power and Control Wheel, but they look at these tactics with an HIV lens. So for instance, if you want to pick one out, let's look at using children. So this might be the perpetrator or abusive partner threatening to take the children, or threatening to use the HIV status of the victim with court or with DHS. It may be using children to take sides. If we look at something like medical abuse, it might be not allowing, and this was commented on by one of the people in the video clip that you just looked at, but not allowing the victim to attend medical appointments, or interfering with medication and health routines, withholding or disposing of medication. So there are many, many behaviors, many of which are controlling behaviors. We're not even looking at, in this way, the physical and sexual violence, which may also be present, or which may be used as threats. What I do want to reiterate here is that controlling behavior is more predictive of a negative outcome than any other behavior. And that's because people who feel like they are losing control or have lost control will do just about anything to regain it. So you cannot talk about HIV risk without discussing physical and sexual violence against women, whether it's actually perpetrated, whether it's used as a threat. But if you look to the right, you see this cycle between violence, HIV risk, and HIV infection. And it's somewhat of a catch-22. In other words, it's really hard to intervene and to escape from that cycle once you're in it. And we're going to talk about why. So here are some of the HIV risk factors with female IPV survivors. It may be higher risk sexual behavior, oftentimes beyond control of the survivor. So it might be the abusive partner who prostitutes you, or who forces you to have sex with other people, or to have sex with that person and other people. It can be any number of things. Or it can be somebody who herself has multiple partners or takes more risks. But what we know is that men who are violent generally have more sex partners and more frequent sex. But you also might have less ability to manage health conditions, attend medical appointments, obtain medication, some of the things that the Power and Control Wheel referred to, and one of the speakers in the video clip. What we know that what happens when somebody is unable to manage one's health conditions is that this leads to poor treatment outcomes. And of course, it is more challenging to practice self-care, to eat well, to sleep well, to get adequate physical activity, parent and homeschool children, manage stress when you are walking on eggshells and when you're worried about what you are going to be blamed for, or whether you're going to be accused of something, or whether you just feel isolated from friends and family and your support system. The HIV risk factors with gay and bisexual men and men that have sex with men are often unprotected sex, multiple partners, limited support networks, homophobia, biphobia, transphobia, sometimes internalized homophobia, sometimes drug use, not taking PrEP or ART, and frankly, an insensitive healthcare team who perpetrate stigma, especially on Black, Indigenous, people of color who are sexual minorities. And remember, I talked initially about some of that is explicit, but some of it is implicit. It's subconscious. It's something that people are not even aware of, which is why it's so important for us to be looking at ourselves in the mirror and really paying attention to our biases. And then there's the HIV risk factors with transgender female survivors. There is limited data on this population, but the data suggests that the violence that is perpetrated against this community, and the most violence is perpetrated against this community, is based on stigma, rejection, and an overall insensitivity to issues of gender identity. And I would like to add it, and it's not only insensitivity, it's lack of awareness, it's ignorance about issues of gender identity. It also may be higher risk due to receptive anal sex without a condom or medication. And frankly, sexual networks are much smaller, and sometimes sex is exchanged for drugs, money, housing, or other things that people might need. So overall, IPV is an under-recognized barrier to the treatment of any patient's ability to obtain regular medical care for HIV. I'm going to give you some examples, based on some of the studies that have been done. But before I do that, I also want to mention that these patients may also be at higher risk of substance use and abuse and mental health disorders, including, but not limited to, depression, anxiety, suicidal ideation, and post-traumatic stress disorder, or if it doesn't meet the diagnostic criteria for PTSD, just post-traumatic stress symptoms. Here are some of the numbers that I promised. So if IPV is present, a person with HIV is 3 times more likely not to be linked to care within 90 days, is twice as likely to be lost to follow-up. And somebody that is dealing with IPV is 4 times more likely to even develop HIV or other STIs, sexually transmitted infections, in the first place. So if IPV is present, somebody that's diagnosed with HIV is half as likely to be on antiretroviral therapy, is 2 to 3 times more likely to be non-adherent with medication. And from a small study that was done with men that have sex with men, 39% of them experienced physical abuse. So an even higher level of domestic violence. And if IPV is present, somebody that has HIV is more likely to have experienced physical and sexual abuse as adults and after diagnosis, more likely to report inconsistent condom use, pregnancy, and abuse after requesting condom use, and 2 to 3 times more likely to be non-adherent with medication. There is an evidence-based practice that was developed by Futures Without Violence that's called CUES, And it stands for, the C stands for confidentiality. So one is it's really important to share confidentiality requirements with the patient. The U and the E stands for universal education and empowerment. So we want to make sure people are screened. And then no matter what the response to the screening is, whether they disclose or not, we need to be providing universal education and empowerment. Because you may screen in a way that somebody feels uncomfortable about responding truthfully to. They may not know what you're going to do with the information, or they may not be comfortable with what potential consequences there are, or they just may not trust you, or it's the first time that they've met you. So no matter what somebody says after you screen them, you want to provide universal education and empowerment. And then the S stands for support. What patients tell us time and time again is that they want somebody who's going to validate and support them and tell them, you know, I care about you, I'm worried about your safety, but to be non-judgmental and compassionate, not to be blaming and shaming. So part of the Q's statement, the confidentiality statement, might sound like this. This is something you might say to somebody before you ask them. In terms of screening, I've begun to ask all of my clients or patients about control, abuse, and violence in their relationships because it's really common and can impact your health and well-being, and more specifically, your risk of HIV infection. It's totally up to you to decide what you'd like to share. And everything you tell me is confidential and will not be shared with anyone else unless I learn that children have been harmed or that you are planning to harm someone else or yourself. So that could be not, and you can make it fit you and your language, and you can change it and modify it in whatever way you feel comfortable. But this is the gist of what we're talking about when we say share confidentiality requirements. So what else can we do? We can listen and believe survivors. We can help them safety plan and do options counseling. If you're not familiar with that or comfortable with that or don't have time to do that, you can refer them to the social worker or behavioral health consultant on the staff, or you can refer them to the hotline, the Philadelphia hotline. We want to make sure that we support what the survivor wants to do, not tell them what they need to do. They already have somebody telling them what they need to do and what they should do. If they don't want to pursue any of those options, what I have been very, very pleased with is the ability to refer patients to the My Plan app. It's a free app that you can put on your phone. It looks like a leaf that's on the top right quadrant of this slide. It is an app that's available in English and Spanish, and it personalizes the situation for you. So you can safety plan on the app. You can they'll ask you questions about your relationship and help you determine whether it's a healthy or an unhealthy relationship. It's especially helpful to use for people who either can't get out of the house or because it's COVID time right now and lots of organizations are closed for in-person counseling, or for somebody who can't even talk on the phone or use a computer or a tablet or some other device. So the phone is sometimes the only option for people. And then have the health center and you as staff be open, safe spaces and places for patients to come for support and care. The National Network to End Domestic Violence developed this toolkit, the IPV Health Partners Toolkit, and some of what they have suggested are appropriate times for having a conversation with people who are HIV positive. Of course, the patients must be by themselves, but this could be during intake or pre-test counseling or post-test counseling. It can be during a risk assessment or when taking a sexual or drug history. It can be whenever partners are discussed or whenever there's a new partner, or it can be during safer sex discussions or when discussing possible reactions to the results of an HIV test. Futures Without Violence has developed a curriculum which is free of charge and can be downloaded, called Gender-Based Violence, Health, and HIV. And it is, here's the website is on the bottom of the slide. It is really helpful because it can provide for you some scripted material. So in case you're unsure about how to say certain things, it can help with that. I have found it very, very useful, very, very helpful. Futures Without Violence also have safety cards. These two in particular are related specifically to HIV and relationships, and they're free. You can get up to 300 at a time. Many of the cards, but not all, are in English and Spanish, and you do have to pay for shipping, but otherwise it's a free resource. I have distributed some of these cards to some of the health centers. If I saw you in person last year, I delivered some health safety cards to you. So some of you already have them, but you can order them. Here are some scripts on one of them, just as an example. So you might say to a patient, anal sex without a condom puts you at much higher risk for HIV because of the higher chances that blood, semen, and other fluids could be exchanged and that anal tissues be torn. And you want to, ask yourself, as you're talking to the patient, you're saying, ask yourself, do I feel safe talking to my partner about sex that lowers my risk but still feels good? And ask yourself, could my partner be infected? And then you might say to them, if wearing condoms is not an option for you, we can talk about PrEP. So of course, this isn't the first sentence you say, but this is just in the midst of a conversation. They really spell it out and give you some great ideas. So as a reminder, most of the IPV that exists will not be visible to you. So if you're looking for a black eye, then you are missing most of the IPV that I referred to earlier, because most IPV is around controlling behavior. That's why it's up to you to ask, to screen, and to screen fully about all behaviors, not just physical behaviors. Your goal is not disclosure. So it's not as important for somebody to say, yes, I am a victim. Yes, I am a survivor. Or, yes, I'm going through this. Your goal should be safety and health and well-being, which is why it's so important to provide information no matter what the disclosure is. And remember that your patients may not be able to share this information or talk to anybody else about it. Maybe the only opportunity that they have to be alone is when they're in their appointment with you. And so as a final note, I would like to say that your patients are depending on you. Your intervention can truly save lives. And I know that you are all in a unique position to sometimes prevent, but certainly to screen and to intervene with this serious public health issue. Please feel free to reach out to me should you have any questions, need resources, or have any other concerns that I might be able to help you with. Thank you so much. Stay safe and stay healthy. And I look forward to seeing you, I hope, next year.